Patrick Hutzel from IntensiveCareHotline.com, where we help families of critically ill patients in intensive care improving their lives instantly so that you can exercise power, influence decision making, and stay in control of your critically ill loved one's destiny. Welcome to another ebook and video in IntensiveCareHotline.com's ebook and video series. And once again, congratulations for taking action in getting informed and taking control. Just by doing that, you stand out from the crowd of the rest of the families in intensive care, and it will give you an edge when dealing with the challenges, difficulties and complexities in intensive care. Our ebook and video series will help you finding your voice, will help you taking control, power and influence decision making in the jungle of complexities surrounding the critical illness of your loved one in intensive care. In this very important ebook, you learn the 5 things you need to know if the medical team in intensive care wants to limit treatment, wants to withdraw treatment or life support, or wants to issue an NFR, not for resuscitation order, for your critically ill loved one in intensive care. In this video, you will discover how to influence decision making and have power in the situation quickly, how to have more control and more negotiation power, how to position yourself well mentally, how to use your gut feeling to determine the right course of action, how to ask for the intensive care unit's policies, procedures and guidelines that may guide or even determine the decisions about treatment limitations, withdrawal of treatment and NFR for your critically ill loved one. You will also discover how to let the intensive care team know that even though you are not a health professional, you have a very good understanding of what is happening behind the scenes in intensive care and that you speak the secret intensive care language. Now, the things that I'm talking about is generally a highly emotionally charged topic outside of the public eye. Okay, so this is another very hot topic and a topic that is not very often discussed in the public arena for a number of reasons. It's a highly charged, a highly sensitive and a highly emotional topic, and you want to know what is really happening if your critically ill loved one is in the situation that a withdrawal of treatment or treatment limitation is something that the intensive care team is considering. It's also a topic that comes with massive moral, ethical and sometimes legal implications and challenges as well. One of the reasons is that, of course, if your critically ill loved one in intensive care is in a critical condition and treatment limitations, withdrawal of treatment and or not for resuscitation or NFR is something the intensive care team considers or suggests you and the intensive care team would want to have a private and open discussion and not a public discussion about the issues at hand. There are, more often than not, conflicting views about treatment limitation orders, withdrawal of treatment and NFR. And so there should. People have different values and beliefs, different cultural, different religious and different spiritual beliefs and values. So there must be different views, and it's good and healthy to have different views and to have a healthy debate. First off, be aware that there is very little standardized literature or standardized approaches about the limitation of treatment, withdrawal of treatment and NFR. Very few hospitals and intensive care units have their policies, procedures and guidelines about end-of-life issues such as treatment limitation, withdrawal of treatment and NFR in the public domain. Hospitals and intensive care units tend to be very secretive about their policies and procedures in these very important and also highly sensitive areas. It is very often up to you and your family to find out these policies, procedures and guidelines surrounding these massive ethical, moral, highly emotionally charged and very often grey issues. One of the reasons why intensive care units and hospitals don't want to have their policies and procedures and general information about and regarding limitation of treatment, withdrawal of treatment and NFR is crystal clear to somebody who has worked in the system for such a long time, but it's often hidden for families of critically ill patients. It's crystal clear that the intensive care team wants to make the ultimate decision, and it's therefore that hospitals and intensive care units don't want to get you involved in those decisions. It's therefore that they don't want you to look at those policies and procedures, and it's easier for the intensive care team to tell you and also quote unquote sell you what is quote unquote in the best interest for your critically ill loved one. After all, most of those policies and procedures regarding decision making around limitation of treatment, withdrawal of treatment and or NFR clearly state that all parties involved would have to agree. But that's not what the intensive care team wants to have happen. They want you to stay out of the decision making process because that would give you and your family far too much power, control and influence. Let's therefore quickly look at the definition of the three main terms that we are talking about in this ebook. Because of the lack of standardization, treatment limitations, withdrawal of treatment and NFR orders are very much dependent on individual intensive care units, policies and procedures. In more than 14 years intensive care nursing in 3 different countries, I have also found that different intensive care units have different cultures, different people have different views, and that therefore it all depends. It's usually never black and white, and there are a lot of grey areas. That's why it's so important that you educate and inform yourself about these sensitive, often highly charged and highly emotional topics. Please also keep in mind that I'm specifically talking about and giving out information about intensive care. Different rules and different perceptions are being used outside of intensive care. So, let's look at the definitions. Treatment limitation in intensive care. A treatment limitation or a treatment limitation order or plan that is documented is an order usually issued by the most senior intensive care consultant, doctor or physician in intensive care. The treatment limitation order is normally based on the grounds that your critically ill loved one is very critically ill and not curable, and therefore a full continuation and a maximization of treatment and therapies would not be achieving a desired health outcome. If anything, it would be likely that a prolonged suffering for your loved one would take place if treatment was maximized, and it wouldn't be in the quote-unquote best interest for your critically ill loved one. Usually, a limitation of treatment also means that life-sustaining medical technology and techniques such as cardiopulmonary resuscitation, ventilation, nutrition and hydration, dialysis, blood transfusions and antibiotics are to be limited. A treatment limitation should only be documented after open discussions with the critically ill patient's family have taken place. Furthermore, all parties involved need to understand and agree on the implications of such treatment limitations. The treatment limitation plan should only be put in place after mutual agreement between the intensive care team and the patient's family has been achieved. Let's look at the definition of withdrawal of treatment in intensive care. In intensive care, a withdrawal of treatment is usually the withdrawal of a life-sustaining treatment that has already been started. This means in practice that life-sustaining treatment such as mechanical ventilation, medication therapy, dialysis, blood transfusions and antibiotics are to be taken away, and they are not to be recommended from the point of decision to withdraw going in the future. The rationalization or driver behind the withdrawal of treatment is usually that life-sustaining treatment would not be quote-unquote in the best interest of a critically ill patient and would only prolong unnecessary suffering of a critically ill patient in intensive care. It's often rationalized with quote-unquote futility of treatment. Futility of treatment is often referred to as treatment to a patient when there is no reasonable hope of cure or benefit. This may in form of a surgeon operating on a terminal cancer patient, or doctors or nurses keeping a brain-dead person on life support machines other than to harvest their organs. It's a highly sensitive and highly emotionally charged area that often causes conflicts between intensive care health professionals and patients and their families, who expect everything possible to be done for their critically ill loved one in intensive care. I am not further evaluating on futility of treatment, as it is a term not used as often as withdrawal of treatment or limitation of treatment, but it's good that you know what it means anyway, and it ties right in with the information that you want to know more about. A withdrawal of treatment should only be documented after open discussions with the critically ill patient's family or with the critically ill patient, if conscious, have taken place. Furthermore, all parties involved need to understand and agree on the implications of such a withdrawal of treatment. This should only be agreed upon once mutual agreement between the intensive care team and the patient and/or the patient's family has been achieved. Let's look at NFR, or not for resuscitation in intensive care. An NFR or not for resuscitation order, and in some hospitals it might be referred to as DNR, which stands for do not resuscitate, is a specific order on a specific document that states that in the event that a patient's heart stops beating, or in the event that a patient stops breathing, that no life-saving measures such as CPR, which is cardiopulmonary resuscitation, and no mechanical ventilation should be initiated. It is usually a subgroup of the treatment limitation order, and once a treatment limitation order has been agreed upon, an NFR order might be the logical consequence. This is usually a response to a critically ill patient's maximization of treatment in intensive care, with the exception that an extension or a prolonging of a patient's life would only prolong the patient's suffering, and that a minimization or a palliative care approach of treatment might be quote-unquote in the best interest of a critically ill patient. This should be documented by the ICU medical team on the NFR form, and written consent needs to be given by the critically ill patient's family. Now, I need to give you a warning here. You should always check and also make sure that none of the above mentioned treatment limitation, withdrawal of treatment and/or NFR have been documented in your critically ill loved one's medical notes without you and/or your family knowing about such orders and/or knowing about that such a documentation exists, without you, your critically ill loved one and/or your family giving consent. Unfortunately, in more than 14 years intensive care nursing experience in 3 different countries, I have witnessed in some intensive care units that treatment limitations withdrawal of treatment and or NFR have been documented, even though families of critically ill patients and or patients themselves, if conscious, didn't know that these documents existed. This is illegal, of course, and if found out, doctors who issued such documents could be sued, as their practice is basically denying basic human rights. Now, I know this was a little bit of a long intro, but now let's look at the 5 specific things that you and your family need to know about treatment limitation, withdrawal of treatment and NFR. And I've given such a long intro to sort of give you some background on what we really talk about and what I'm about to cover. So let's look at number 1, which is transparency, openness, consideration and due diligence in the decision-making process are paramount. You might think that this should be a no-brainer, and I totally agree. It is a no-brainer. Transparency, openness, consideration and due diligence are paramount in this hot topic. Some intensive care units are very good and very open about end of life and treatment limitation issues, and others simply aren't. It also might vary within an ICU, where some of the medical and nursing staff are open, transparent and considerate, whereas other medical and nursing staff have differing views, and they might also be less open to differing views. But what exactly do I mean by transparency, openness, consideration and due diligence in the decision-making process? Is there a distorted reality? Well, a lot of the issues that I have informed you about in intensivecarehotline.com's ebooks, videos and blogs are issues that I have encountered over and over again in more than 14 years intensive care nursing, and there is often a real power struggle for families of critically ill patients. Unfortunately, there are a lot of moving parts behind the scenes in intensive care that you are totally unaware of, and therefore what you actually see and what you get told is often not what you get, and you might be dealing with a distorted or twisted reality. The intensive care team, generally speaking, is trying to hide away from you what's happening behind the scenes, so to speak, because what's happening behind the scenes often has a dramatic impact on the intensive care team's positioning, and it generally impacts one way or another on your critically ill loved one's treatment. So let's give you an example here. Your 55-year-old husband has been admitted to intensive care. Your 55-year-old husband has been suffering from leukemia for the last 3 years, and he has already been through hell, and he has had multiple chemotherapies as well as having a bone marrow transplant about 2 years ago. Your husband has been feeling up and down during the last 3 years since first diagnosed with leukemia. So has your family. It has been an extremely difficult time and an emotional roller coaster for you, for your husband and for your 5 children. Your husband has never given up, and he has a very strong will to live, and you are thinking to yourself that everybody else would have probably thrown in the towel by now. He has also managed to stay out of intensive care thus far, despite many setbacks and disappointments in his treatment. Your 55-year-old husband has been admitted to hospital about 2 weeks ago, as he had developed pneumonia from his recent chemotherapy. He struggled on the ward, required increasing amounts of oxygen, and he finally had to be admitted to intensive care as the ward staff were unable to manage his deteriorating condition any longer. Once in intensive care, your husband was put on non-invasive or BiPAP mask ventilation, a form of ventilation that doesn't require sedation or an induced coma, but it does require for your husband to be able to tolerate a tight face mask, oxygen and a lot of pressure filling his lungs in order to treat the pneumonia. you can see that your husband is struggling, and you can also see that the BiPAP ventilation is helping him. But you can also see that it's very tiring and exhausting for your critically ill loved one. You also know that your husband wants to live. He still has his zest for life. You are at your 55-year-old husband's bedside, and the intensive care team approaches the bed space to examine him. They do want you to leave the room while they examine him, and they will get you back in to have a chat once they have finished their examination. After about 30 minutes, the bedside nurse Sarah comes to collect you at the ICU reception, and you go back into the unit. The intensive care medical team is waiting for you, and they suggest a meeting with you in a few hours, preferably with some of your children around as well. They don't want to have a discussion about managing your husband's further stay in intensive care and his prognosis. You're already thinking that if they want your children to be present, it might be bad news. Given that only 2 of your children are living locally, you'll ring them and you ask them to be in ICU by 5 p.m, which they agree to. In the meantime, you can see your critically ill loved one struggling on the BiPAP ventilation more and more, and you wonder what might be next. You can see that he's not coping, and you are very concerned. You ask the bedside nurse Sarah what the next steps might be if your husband doesn't improve on the BiPAP ventilation. The bedside nurse says that the next step would be mechanical ventilation with an endotracheal breathing tube, but she's unsure whether that's something the intensive care team wants to initiate, and that it's something they want to discuss with you and your family later today. At 5 p.m, you and the 2 of your children are greeting the intensive care consultant or physician, one of his senior registrars, and the bedside nurse Sarah. The 6 of you enter the ICU meeting room, and the senior ICU consultant or physician opens the meeting. He explains that your 55-year-old husband has been admitted to intensive care for his deteriorating pneumonia, which they believe to be a direct result of his recent chemotherapy. The consultant says that unfortunately many chemotherapy patients with leukemia end up in intensive care with pneumonia, as the chemotherapy weakens the general immune system, and therefore infections such as pneumonia develop. Furthermore, the ICU consultant or physician says that your husband's white cell count, which is the white blood cells that are cells of the immune system defending the body against infections, are minimal, suggesting that his body might be in a weak position to defend and fight the infection. Your husband has also been commenced on antibiotics for the pneumonia. The intensive care consultant or physician continues by saying that given the overall clinical picture with your husband's requirement for increasing oxygen demand and his struggles on the BiPAP ventilation, that he would require intubation and mechanical ventilation. He would therefore require to be in an induced coma. The senior intensive care consultant or physician also says that given the clinical picture with your 55-year-old husband's ongoing leukemia, ongoing chemotherapy, and probably limited life expectancy, that he has concerns that if the intensive care team was going to put him on a ventilator with an endotracheal tube, that he would not be able to come off the ventilator quickly, that he might be too weak to breathe by himself without ventilator support. The intensive care consultant or physician therefore suggests 2 ways to manage the situation. A. Leave your husband off the ventilator, support with BiPAP or mask ventilation, making sure your husband is comfortable, and let nature take its course, and in that course your critically ill husband could potentially die. Or B. Put your husband on a ventilator with an endotracheal tube and induce him into a coma. the intensive care consultant or physician has concerns that your husband will not manage to come off the ventilator once on mechanical ventilation. He therefore fears a prolonging of your loved one's suffering, and he can't guarantee that mechanical ventilation will cure the pneumonia. The intensive care consultant furthermore suggests that if they did ventilate and intubate your critically ill loved one, that a quote-unquote one-way extubation would be the best course of action. You ask what a one-way extubation means, and the intensive care consultant explains that once your husband comes off the ventilator, he wouldn't be for another intubation and mechanical ventilation. One of your children asks whether this would be a sink or swim approach. The intensive care consultant or physician confirms that this would actually be a sink or swim approach. He then further asks whether you or your children have any questions thus far. You and your children deny having any questions. The intensive care consultant or physician continues, saying that they would need to make a decision very soon, because if the medical and nursing team were going to mechanically ventilate your critically ill loved one, they would need to do that soon, as there are more staff around before 10 p.m. as there are less staff on night duty. You and your children look at each other, and for you and your children it's not even something you even have considered, that you would let your husband and father die without even trying. You and your children are crystal clear about the wishes for your husband and father, and you explain what a strong will to live he generally has. The intensive care consultant or physician continues to have a grim look on his face and says that they would want to put your 55-year-old husband on the ventilator if you would want that, but he also suggests that the intensive care team has come to the conclusion that if your husband was going to be mechanically ventilated and in an induced coma, that he would want to issue and document specific treatment limitations, including NFR or not for resuscitation, in case your loved one's heart stops, and that if your husband should go into kidney or renal failure, that he should not go on a kidney machine or dialysis. The intensive care consultant or physician explains that he doesn't think that CPR or cardiopulmonary resuscitation and dialysis would be in the best interest of your critically ill loved one. You and your children look at each other in disbelief. You always knew that your husband was very sick with leukemia, but you didn't expect him to crash to the point that extensive treatment wouldn't carry him further on his journey through life. The intensive care consultant is adept at reading your and your children's body language, and there is an awkward silence in the room for a minute or two. You can feel tears coming up 10 minutes ago, and you were able to hold them back then, but now you let them roll and you grab one of the tissues on the table. Now you are sobbing uncontrollably. One of your children puts their arm around you and you are looking for words. Finally, one of your children gets crystal clear and says that you and your family don't want any treatment limitations at this point in time, and that you and your family want everything done for your husband and father. We leave this fictional meeting now and we zoom out, and I hope that this example shows you where the issues and challenges are. Without putting too much judgment on what either the intensive care team's view is and what your views are, those or similar situations occur in intensive care units at all times, and those situations tend to be very challenging, difficult, and very rarely are those challenges and issues black and white. You also need to know and understand that the positioning of the intensive care team was clear from the start, and that the team had talked amongst themselves before the meeting, regardless of your views and opinions. That's why it's so critically important that you are mentally well positioned, mentally well prepared, and that you have as much insider information as possible in those situations. On the one hand, there are you, your family, and the love and concern for your husband who wants to live. On the other hand, there is the intensive care team who knows and understands the clinical implications of your 55-year-old husband's diagnosis and prognosis. There are a number of challenges that the intensive care team is dealing with in the background that you are totally unaware of, and I won't go into detail here. For more information, you can tap into our other ebook or video and read or watch the 7 questions you need to ask the most senior doctor, most senior physician, or most senior consultant in intensive care if your loved one is critically ill. And you can also read our ebook or watch the video on 10 things doctors and nurses are talking about if your loved one is critically ill in intensive care when you are not present at the bedside, because I shed more light on what's happening in the background in those videos and ebooks. What is important for you to know is that you have made your wishes and views very clear from the start, and so has the intensive care team. As you can find from the discussions in the meeting, the intensive care team has already made up their mind to where things go from here. You need to be very mindful what is getting documented though. In many instances that I have seen over the years, and in many similar instances I have witnessed that the exact things that the ICU consultant or physician mentioned about treatment limitation and NFR would be documented without you knowing that it has been documented already in the medical notes. This is illegal, and it's breaching many policies, procedures, and even laws. It would even mean that the intensive care team knows what has been said in the meeting because it's usually documented. The crux, however, is that you would have to agree to a limitation of treatment and NFR, which you clearly haven't, like in our fictional meeting. There are also formal processes in forms of policies and procedures regarding treatment limitations, NFR, etc. Those formal processes would have to be adhered to, and it usually includes your consent to the management plan for your critically ill loved one. The reality often is, however, that those policies are ignored. You as a family member or next of kin of a critically ill patient in intensive care is unaware that such policies and procedures even exist. You therefore need to ask for the management plan for your husband if it adheres to and complies with the intensive care unit's policies, procedures and guidelines regarding limitation of treatment and NFR. You also need to ask whether the documentation about the meeting in your husband's medical notes and the formal policies and procedures regarding treatment limitations and NFR. I can tell you that just by asking for those documents, you will be viewed very differently, and you will have instantly more control, more power, and more influence. You will show that you are not giving up lightly. You will also find that by asking succinct questions that the dynamics will shift immediately. You might also think that you and your children want more time with your husband, even if it's only a few more days or weeks. These are exactly the points where most families of critically ill patients in intensive care fall short, and this is exactly why they are not influential, and this is why the intensive care team has all the power. Families of critically ill patients in intensive care lack the insider knowledge that leads them to asking succinct and important questions. Just by doing that, you will see the dynamics shift immediately, and you will see that you have control, power, and you have an ability to influence decision making. Furthermore, Listen to your gut. If your gut tells you that your husband would want to continue treatment, then you need to stand up for that. If you feel like your husband had enough, well, then maybe it is time to let him go. Always ask lots of questions. Don't worry what the intensive care team thinks about you asking lots of questions. It's none of your business what they think. Intensive care is a busy, stressful and challenging environment, and for you, for your family and for your critically ill loved one, it's often a once-in-a-lifetime experience, and you don't want to get it wrong. This is the first part of the video, and I'll invite you to come to the next part of the video that's just below. Thank you. See you there.